Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 432 of our pharmacotherapy series, which majors in adverse effects of chemotherapy and targeted agents. The next case reads, CLM, a 32-year-old woman with recently diagnosed stage 2 breast cancer, underwent a lumpectomy and external beam radiation therapy and is scheduled to begin adjuvant chemotherapy with doxorubicin and cyclophosphamide followed by paclitaxel, ACT. CLM was married 12 months before her diagnosis and wishes to have children. What are CLM's prospects for fertility after adjuvant chemotherapy? Cytotoxic chemotherapy is potentially gonadotoxic in humans. Ovarian biopsies taken from women treated for cancer demonstrate loss of ova and follicular elements. This injury is evident even in prepubertal female patients treated for cancer. Ova die or become non-functional by direct injury to the ova or by indirect injury resulting from loss of supporting follicular cells. If the damage to the follicular elements is extensive and irreversible, fertility is impaired even if the ova are spared. Agent-induced injury to ova and follicular elements reduces ovarian estrogen and progesterone secretion in menstruating women. This causes the hypothalamus and pituitary to secrete more follicle-stimulating hormone, abbreviated as FSH, and luteinizing hormone, abbreviated as LH, which in turn increase follicular recruitment and the number of follicles vulnerable to cytotoxic chemotherapy agents. If the gonadal toxicity is severe or prolonged, permanent ovarian failure can occur secondary to depletion of ova and follicles. Recovery of some of the affected follicles often occurs, however, and this may be manifested by irregular menses or delayed recovery of menses. If the ova are spared and follicular cells recover sufficiently, ovulation and pregnancy might occur, but premature ovarian failure is inevitable in most women treated with large doses of gonadotoxic agents given for long periods. Prepubertal girls have a greater reserve of primary follicles. Because their ovaries are not producing estrogen and progesterone, increases in follicle-stimulating hormone and luteinizing hormone with resultant recruitment of follicular elements do not occur. For this reason, prepubertal girls can tolerate large doses without apparent effects even if the pathology previously described occurs. The gonadal effects of cytotoxic chemotherapy in women and girls have been described in several reviews. CLM is going to receive one of the alkylating agents, which are the most potent gonadotoxic agents. Cyclophosphamide is well known for producing infertility in men and women and gonadal failure even in children. The effect is influenced strongly by the total dose of cyclophosphamide and the patient's age at the onset of chemotherapy. Nearly 100% of women older than 20 years of age experience amenorrhea when the mean total dose is 20 to 50 grams. The same consequence can be expected in women older than 35 years of age who receive greater than 6 to 10 grams and in women 40 years of age and older who receive more than 5 grams. Depending on the exact dose of cyclophosphamide in the ACT regimen planned, CLM may or may not fall into a dose range that would be expected to produce permanent amenorrhea. The clinician also must consider that a synergistic gonadotoxic effect has been reported when doxorubicin is combined with cyclophosphamide. Aside from the alkylating agents, the only agents with strong evidence of gonadal toxicity include vinblastine, etoposide, and cisplatin. Several resources discuss the doses of chemotherapy agents, used both alone and in combination, and specific incidences of associated gonadotoxicity, as well as the prevalence of temporary and permanent amenorrhea. CLM most likely will experience amenorrhea along with the signs and symptoms of menopause as both estrogen and progesterone production diminishes during cytotoxic chemotherapy. CLM may recover from chemotherapy-induced amenorrhea months to years after completion of her therapy. Recovery may be manifested as amenorrhea interspersed with normal menstrual periods. Pregnancy is possible during periods of normal menstruation because ovulation does occur in most instances. Premature menopause is inevitable, however. Because the greatest risk of pregnancy exists early in the course of therapy, CLM should be counseled to practice birth control while receiving cytotoxic chemotherapy. Because oral contraceptives are contraindicated in patients with breast cancer, barrier methods, i.e., diaphragm, condoms, or spermicide, should be advised. The next case reads, JKL, a 25-year-old man with recently diagnosed testicular cancer, will receive systemic chemotherapy with bleomycin, etoposide, and cisplatin. So my question to you reads, what effect does systemic chemotherapy have on male gonadal function? The primary gonadal toxic effect of cytotoxic chemotherapy agents in male patients is a progressive dose-related depletion of the germinal epithelium lining the seminiferous tubule. The clinical manifestations of germinal depletion include a marked reduction in testicular volume and azoospermia. The Leydig cells responsible for testosterone production remain morphologically intact, although mild functional impairment occurs rarely. The major toxicity of chemotherapy in men is loss of reproductive capacity. During treatment, libido and sexual activity may decline, but most men report a return to pre-treatment sexual function after chemotherapy. Of the cytotoxic chemotherapy agents, alkylating agents are associated most commonly with azoospermia. Progressive dose-related oligospermia occurs in men receiving chlorambucyl cyclophosphamide melphalan, busulfan, procarbazine, and nitrosoreus. Procarbazine appears to be the most gonadotoxic alkylating agent in men. Doxorubicin, vinblastine, cytarabine, and cisplatin also have been associated with azoospermia, and doxorubicin appears to have a synergistic toxic effect in men when given with cyclophosphamide similar to that previously described in women. Phase-specific agents, such as antimetabolites and vinca alkaloids, seem unlikely to produce azoospermia when used alone, but may play a minor role in combination chemotherapy regimens. In contrast to oogenesis, in which women are born with a full complement of ova, spermatogenesis occurs in a continuous cycle of regeneration, differentiation, and maturation beginning in the second month of embryogenesis and continuing through old age. Although different cytotoxic chemotherapy agents appear to exert more damage to germ cells in specific phases of spermatogenesis in animal models, in humans, gonadotoxic agents generally are used in sufficiently large doses to affect varying proportions of maturing sperm cells in any stage of development. This has two realistic implications. The first is that because spermatogenesis must start at the beginning after agent-induced azoospermia occurs, the length of recovery is prolonged, usually lasting at least 2 to 3 years. The second is that the relationship of age to the development of azoospermia is far less clear than the relationship of age to ovarian suppression. Although conventional wisdom holds that prepubertal boys are less likely to be affected by chemotherapy agents than adult men, the reserve of primitive sperm cells in male children is far less than it is in adults. Therefore, the spermatogenesis potential in prepubertal testes may make them more vulnerable to cytotoxic damage than those of adults. A review of the literature regarding the effects of cytotoxic chemotherapy administered to male children concluded that agents and regimens known to be toxic in men should be considered toxic in young boys. Short of a testicular biopsy, the damage cannot be detected until puberty. The two diseases most likely to affect young men who are concerned with their fertility are Hodgkin lymphoma and testicular cancer. The standard treatment for advanced Hodgkin disease is ABVD. Azoospermia has been observed in 35% of patients receiving ABVD, and spermatogenesis nearly always recovered in these patients. A similar scenario exists in patients about to start on chemotherapy for testicular cancer. Evidence to date suggests that therapy-induced azoospermia that follows treatment with vinblastine, bleomycin, and cisplatin for non-seminomatous testicular carcinoma is reversible within 2 to 3 years in approximately 50% of patients treated, and that those who recover spermatogenesis are capable of impregnating their partners. In this particular patient population, it is important to recognize that retroperitoneal lymph node dissection, which results in retrograde ejaculation, as well as cryptorchidism, which predisposes to infertility, may contribute to the lack of full recovery of fertility potential. My next question to you reads: aside from the use of anti-cancer therapy agents with less gonadal toxicity, are there means of circumventing infertility in young patients such as JKL receiving therapy? Sperm or gamete cryopreservation should be considered in males. A major limitation of this approach has been the finding of diminished sperm counts, sperm volume, and sperm motility in young men affected with Hodgkin lymphoma and testicular cancer even before combination chemotherapy is initiated. Although published studies suggest that the quantity and motility of sperm are important determinants of successful artificial insemination, pregnancies have been reported. Thus, sperm banking should be considered even in oligospermic men. Oocyte cryopreservation and embryo cryopreservation now are feasible options for young women about to undergo cytotoxic chemotherapy. Even in the face of cytotoxic chemotherapy-induced ovarian failure, in vitro fertilization of an ovum and implantation into the endometrium with proper hormonal support can successfully accommodate a term pregnancy. This may be an option for females. In both sexes, it has been hypothesized that gonadal toxicity from cytotoxic chemotherapy could be decreased by inhibiting spermatogenesis or follicular development during therapy. Methods used to suppress gonadal function have included administration of testosterone in men, oral contraceptives in women, and gonadotropin-releasing hormone analogues in both men and women. Several reviews describe these approaches in detail, and ASCO provides recommendations on preserving fertility in cancer patients. My next question to you reads: if JKL regains fertility after his planned combination chemotherapy regimens, is he at risk for producing offspring with congenital abnormalities or an excess risk of cancer? Most of the agents used to treat cancer are designed specifically to interfere with DNA synthesis, cellular metabolism, and cell division. Thus, reason exists to suspect that they may cause mutation of ova or spermatocytes exposed to these effects. The actual outcomes of pregnancies in survivors of cancer are published as case reports, small series, and retrospective case series. Nearly 1,600 children have been born to 1,078 patients previously treated for malignancy in childhood or as adults. A review of the published information suggests no evidence that spontaneous abortion, genetic disease, or congenital anomalies occur more frequently in the progeny of cancer survivors. Similarly, there does not appear to be an increased risk of malignancy in the offspring of patients treated for cancer. The likely explanation for this is that ova and sperm cells affected by cytotoxic chemotherapy usually are killed. The risk of producing an abnormal offspring thus would be highest at the time of chemotherapy. Men and women should be explicitly discouraged from conception during chemotherapy. In general, adults surviving cancer should be advised to wait at least 2 years after completion of therapy before attempting to parent a child. This theoretically allows time for elimination of damaged germ cells. This also provides time to assess the likelihood of the necessity for further treatment that would have grave consequences on the fetus, particularly in the case of female patients. So there you have it. Our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 433.